So good afternoon, everybody, and thank you for joining us this afternoon at the MS Academy at this webinar where we're going to talk about sequencing MS therapies, strategies for success. So we want to thank our sponsor, Novartis. So we are your speakers for this afternoon, so welcome. So my name is Kate Petheram. I'm a consultant neurologist working in the northeast of England in South Tyneside and Sunderland. And I'm joined today by Jola Matthews, who's the lead neuroscience pharmacist at Barts in London. And a very close colleague of mine also, Carmel Wilkinson, has very kindly stepped into it to a breach to give us a further northeast input. So Carmel's a MS specialist nurse with lots and lots of experience and has the misfortune of working with me in Sunderland. So here are our disclosures. I'll let you just absorb those. We're all fairly broad and not particularly biased in any way. The objectives of this really is to review the principles of disease-modifying therapies and discuss any pitfalls. And although this is quite tricky to do within a webinar kind of online session, we're going to try and make this as interactive as possible. So we're going to use some case studies from our own practice to illustrate some complex cases. And in the effort of making it interactive, I'm going to ask you to do Q&As after each case. And if you can use the Q&A function on Zoom rather than the chat function, that would be really appreciated. And then we'll have a quick summary at the end, an opportunity if there's any time or any unanswered questions, we'll try and answer those as well. So I thought I'd just introduce the subject by talk a little bit about why talk about switching, why is this relevant to us today? Ideally, we've got an increasing evidence mainly from big registry studies for high efficacy treatment early on in a patient journey. And I think particularly those of us on the call today and the majority of people, working in MS would advocate for high efficacy treatment as soon as possible. But what this data doesn't really tell us is about individual patients, and that's both in terms of disease activity and response to drugs, both at an individual level, but also about those patients' circumstances and their preference. And for those reasons, we continue to have patients start on a wide variety of treatments. Ideally, we want to get the drug, right time, right patient, but that doesn't always happen. And there are many reasons why we may need to switch treatment. So I've just outlined a few. I'm sure people will think of more, but escalating therapy, so disease activity is a reason to switch. Pregnancy is a reason to switch. I kind of perhaps purposely haven't covered that much in this seminar because I think it's covered well elsewhere, but if it comes up, we can try and answer some questions. One of the big reasons for switching, which I'll illustrate, is safety and risk mitigation, particularly regarding JC virus and certain treatments such as Natalizumab. There are comorbidities which may cause patients to switch treatments, perhaps particularly as we're looking at patients being treated with disease-modifying therapies well into their 50s, 60s, and sometimes even 70s. And tolerability are well recognized to kind of be a reason to switch. And sometimes we perhaps don't always think about as a change in circumstance. So when patients maybe move from region to region or change jobs or other reasons why they may switch treatments. So just to look at some data that I mentioned, so we are getting more familiar with big kind of data registries, and this is a big registry data. Well, it's a combination of registries from 5 big registries, and looked at the reasons for switching and number of people switching. And what we see really here is that switching is common. So this is information from over 110,000 patients and looked at 269 changes of treatment, whether that's stopping completely or switching or interrupting treatment. And I think perhaps the most interesting graph is the second graph down, which looks at persistence on treatment. So the percentage of patients continuing on treatment. So if they started on a treatment that year, the chance of them remaining on that treatment at the end of the year. Because our key goal is really to provide patients with a disease-modifying therapy that they're likely to continue with for as long term. And overall persistence we can see is fairly stable, but until the last few years, when about in 2014, we see a decrease in continuations for all drugs, but perhaps most notably for Natalizumab, where the annual chance of continuing on Natalizumab has decreased from about 95% when in the beginning, around 2007, to about 70% in 2016. And that's likely to represent what we acknowledge to be the implementation of the risk management schemes to try and avoid PML. So lots of this data doesn't really tell us why people switch, but it tells us that people do switch. So the information that we have suggests that kind of 2/3 of patients swapped or stopped DMT, and most of those were for switching. The most common reason was for efficacy, so switching up to a different disease-modifying therapy, some for adverse effects, and some for intolerance. I'm not quite sure how they specify the difference between those two. So as all of us know, we know that evident experience guides practice to a certain degree, and some of you may, well, Joe, I'm sure will remember this paper from Gavin Giovannoni and the group, trying to really devise a strategy from switching patients from Natalizumab to the other high efficacy treatment at the time, which was Alemtuzumab. This was bearing in mind prior to us having anti-CD20 treatments. And what was suggested at the time was a bridge with Fingolimod to try and avoid the PML risk, but not what you didn't want to be doing was starting somebody who was perhaps at high risk of developing PML and switching them to Alemtuzumab without the chance to see if they were going to develop it or not. And so the idea was to start Fingolimod, but myself and a few other colleagues across the kind of internationally had patients that relapsed quite catastrophically using this strategy. So that the theory was that if you put someone on Fingolimod and then switch them quite quickly to Alemtuzumab, the circulating lymphocytes haven't got a chance to circulate and then be attacked by the Alemtuzumab. So we're kind of learning as we go along with a lot of these switches, because we don't have very good evidence always to guide switches. So really what we're trying to do is we're trying to gather the evidence, but also balance what we do have. So balance Rebound activity, so efficacy against the safety and the concern about carryover PML, for example, and things like cumulative immunosuppression. So I mentioned Rebound, and this is a really neat study from last year, and it looked at data from two big registries, the MS-based and the big French registry, looking at disease activity prior to and then after treatment cessation. So it's a little bit of a busy slide, but it's worth maybe taking a screenshot and having a look at later. So the gray area is on is the disease activity, so annualized relapse rate on the index treatment. And then beyond that is if treatment has stopped, and yellow suggests that people are untreated, and the blue suggests that people were started on another treatment. And you can, if you look at the numbers, a lot of people who were initially untreated were then switched to another treatment. There were lots of different reasons for treatment cessation. For Natalizumab, it was often a scheduled stop, and most started an alternative disease-modifying therapy after a median of about 2 months. 51% of those were Fingolimod, and it was recognised that commencement of the new treatment within 2 to 4 months reduced the magnitude of disease reactivity. For other treatments, they're generally discontinued due to efficacy, so you'll see that their disease activity goes up prior to the point of switch, and the majority were started on a new, generally high efficacy treatment, and the relapse rate returns to baseline after treatment. The predictions of reactivity are younger age, female sex, higher EDSS score, and higher relapse rate in the prior 12 months, so kind of what one would expect. So I think this is something that comes up in our MDTs, and I'm sure it's familiar to lots, but I found it quite difficult to find guidelines about how to switch people. And I think every centre, I'm sure, will have their own crib sheet about, if someone's switching from this, what's the washout to go to this treatment. But I did find that the French have got some guidelines, and I think this is quite useful. Again, crib sheet. I'm not going to go into it in detail with everyone, but the drug on the left of the screen is the drug that they're starting on, and then the switch depends a little bit on what they're switching to. But for most things, the suggestion is a fairly immediate switch, perhaps with the exception of Fingolimod and Natalizumab switching to a higher efficacy treatment. I put that question mark by teriflunomide because I think most of us would agree we wouldn't switch directly from teriflunomide to another because of the cumulative risk of immunosuppression. And most of, I think, people I work with would do a accelerated elimination if you were going to make that switch, or you've got potentially quite a long wash up. So I'm going to hand over to Jola now to take us through case number 1, if that's okay.
Yeah, that's fine. Thank you, Kate, and thank you for asking me to speak. So the next slide is going to go through a case, and this is a based on a real case, but has been pseudo-anonymized for the chance of the presentation. So in December 2012, the patient was diagnosed with relapsing remitting MS, and severe encephalopathic presentation. They were inpatient. Their EDSS was 5 at the time. So from June to September, they were receiving natalizumab infusions every 4 weeks. And then in September last year, there was a change in the JCV results. They were negative, and then they became high titer positive. So what would you do next? So we're going to put a poll up. The MRI at this point showed no new lesions, and there's no recent clinical activity. So the only change for the patient is that they've had that high titer positive, and you are now worried about JCV and PML risk. So the next slide is going to come up with a poll. So what would you consider doing? So this is you personally. We don't know what your answer is, but we'd just like to engage with the poll. And it's to continue. Would you continue natalizumab but with extended dosing? Would you switch to an anti-CD20? Would you switch to oral cladribine? Switch to an S1P, teriflunomide, DMF, DRF, or beta-ferrochlorotirumab? What would you consider doing? So just think about you personally, what would you do? We know that in most cases, these sort of cases are taken to MDT, so it isn't a single person's approach. You're considering it's a discussion that happens. What would you advocate for? I'll give you another couple of seconds to think about it. But these are the real life cases that happen. As DMTs have been around longer, patients have been on the DMTs for longer, we're going to see more people get adverse events. And I was thinking when you were talking, Kate, the other reason people switch is that new treatments arrive. So obviously when people are diagnosed, some treatments didn't exist. So that might be another reason for, well, not, I don't know, is that a switch or is that something new and exciting's out there? And that might be the clinician like it.
And so I was going to ask Jola, just while we're waiting for people to do more polling, do you think you might have, do you think this would have been maybe a different list if it had been a different time?
Yes.
So a few years ago?
Yeah. I think it would be completely listed. And we are a high treating centre. And so maybe switch to no treatment should have also been an option that I'm now considering, that should have been there. But we at Barts, we treat quite aggressively. And so we always forget that actually always is an option that patients might take. And do we offer that to patients as regularly as we should? I'm a pharmacist. It's weird for me to say, let's offer them no treatment. That'll be less work. Maybe they should all know. Obviously, that's not great for the patient and their disease progression.
And I guess alluding to the other thing which I mentioned was kind of alemtuzumab. We don't have to go into a lot of detail, but that might have been on the list presumably before, particularly before the the restrictions on its use. Yeah, and the lack of other options as well.
Yeah, the lack of other options that really did dictate what people did and people's looking at the risk factors, etc. And MS is a chronic disease. We are treating patients for their life. So other things might come into, and we'll come into some of those with some of the other case studies. I'm hoping we've got some results of a poll that the magicians behind the scenes can now show us what you guys would do. Okay, so 46% will do natalizumab extended dosing, 43% anti-CD20, which is, it probably shows how we are treating MS right now. 4% would do oral cladribine, and I don't think there's anyone else from Barts on the thing, so it's not just a Barts answer. And then you've got the S1Ps too. It's interesting. I think the lack of the lower efficacy treatments offered as a treatment choice shows that we are more aggressive treaters that are probably on the call and listening to this webinar, which is, I would say, a good thing, but obviously there are people that are worried about that. So that, yeah, and so what we did next, so we can close that poll. And so what did we actually do? So we switched to anti-CD20 therapy because the patient, it was available. But this is a really evidence light zone. Like these, there isn't much evidence. There is the registry data that Kate presented, etc. But there really is, we don't have the massive trials on this. There isn't going to be the randomized trials that show or like the switching evidence. And hopefully we'll get that in the future as we can look at the big data better. What would we have done if the patient had developed PML? And we would have done a rebaselining scan at appropriate time points. We would be closely monitoring to check that that doesn't occur. But there is data to support the use of platform injectable therapies, but it's limited. And often we're discussing these key cases in MDT and often involving an immunologist and other specialists. So the MDT doesn't have to just include neuro and MS expertise.
Excellent. And as if by magic, I think I do have a little bit of data because I am a consultant, so that's what we like, right? So there were a couple of recent studies looking at the use of ocrelizumab after natalizumab when patients have become JC positive. And the top one is a Dutch observational cohort of only 42 patients, but they were either switched directly or via another disease-modifying therapy. It's been observed, probably not unsurprisingly, that switching directly was more effective. There were, however, 2 cases of PML in the direct switches, although in hindsight, there were imaging changes prior to the switch. And perhaps more encouragingly, both patients did really well and were continued on ocrelizumab. They advise in this study, their protocol is to do a scan at 3 months and then 6 months after natalizumab cessation in the first year, and then we do an annual study. So that's the kind of Dutch experience about switching. The Octave study is a prospective study looking at natalizumab to ocrelizumab switches. Again, it's smallish, 41 patients, 2 relapses, but with no MR activity, always a bit questionable in my mind, and 2 with new MR activity, but no clinical activity, but no PML, reassuringly, and they suggest an MRI scan at the point of switch and then 6 months later, which is probably roughly in line with what we do. I don't know what others, if you do anything different, Jola.
I think we often rebaseline at the 3-month time point. Often takes that long to organise an MRI scan anyway. So even though they're saying MRI scan at the point of switch, in reality, that's not, it's probably going to be the 3-month point.
Yeah, I think what we would do is probably do it just before switching. So, you're not starting somebody who's got PML on ocrelizumab and then do it maybe 3 to 6 months after that. That's kind of what we would do locally. We haven't got any questions yet, I don't think, but please do feel free to ask questions as we go along. And then just one other study. This is again switching from natalizumab to a variety of different treatments. An observational cohort study from the MS base register, which demonstrates that in terms of time to first relapse and in terms of hazard of treatment discontinuation, then switching from natalizumab to ocrelizumab was associated with lower relapse rates and discontinuation rates as compared with fingolimod and dimethyl rates. So further evidence to back up what we're doing, really, which is always reassuring. So we haven't got any questions as yet, but please, like I said, please do ask questions. So I'm going to hand over to Carmel.
Thank you.
Talk about case 2.
Case study 2. Thank you very much, Kate. Thanks, Jola. So I'm kind of looking at it from a more practical perspective, and this case study that I'm bringing young Charlie, who's aged 25. She was brought to our attention when I was working in Newcastle, and she had pediatric onset MS. So she was pediatric onset, as I've already said, and she was under the care of the pediatric team until 2018, and she started round about 2014 transitioning from paediatric to adult clinic. So she had a very clear path into our service. She had so many other things that happened to her at the time: gut dysmotility, functional bowel disease. She was NG fed in 2011, 2013, and 2015. She had quite prolific eczema at the time that was exacerbated by her long-term anxiety and depression, which obviously came on, well, not obviously, but came on after her diagnosis, and all of the things that affected her, like perianal abscess. She had non-epileptic seizures, which were obviously really quite concerning at the time to everybody, and it took a long time to diagnose. At the time, obviously, she lived with her mum up to and including this year. She's only just moved out in with her partner. And when she first came into us, you're looking at the date 2009, she was treated with IV Tysabri off license at the time, owing to the presence of enhancing lesions, and of course our age. We hadn't quite reached the FINGO paediatric eligibility. So this was the other reason that was taken at the time. We had a really good setup. It was a regional neuroscience centre, really good setup for paediatric neurology nurses. She had her own specific nurse that saw her through, well, up until she came over to us. And the reason for choosing the Tysabri was very much its quick acting nature, its ease of administration while she was in hospital, and for the other reasons, she was in hospital quite a lot during those early years. From the point of diagnosis, we had lots of problems. She was, she was under the care of CAM's team from the point of diagnosis, and continues under their care. Actually, she's only just moved away from them. We sort of, things that happened to her. She responded really well to the treatment. She was doing really well on that treatment. However, during that sort of time of transition from 2014, she became really quite insular. She was unable to, she just became really needle phobic, unable to accept the treatment. We had to insert a portacath, and that sort of changed the face of our treatment at that point. Our transfer into adult services was horrendous for her. She had her mum, who was obviously our fiercest advocate, and those parents out there will understand why you would do that. But it also made Charlie really quite dependent on her mum making decisions for her, and that sort of structured how our care was undertaken by the adult services. So we had a bit of a rocky transfer over. We also had some issues with all of the other services. She was under the care of the gastroenterology team, and they had such a high turnover of staff that she just disengaged from them altogether. And round about 2018-19, Charlie transferred over to Sunderland because her mum and Charlie had completely given up everything, or every sort of hope, because they were so angry with the whole team. So it got to the point where it was a real sort of challenge to get treatment into Charlie. We took a decision because she then was unable to have MRI scans without a general anaesthetic, which again caused dreadful problems because having a general anaesthetic every 6 months is not really gold standard care, and it's not really a successful management path. We transferred her over onto Ocrevus in 2021, and this was just before she moved over to the Sunderland team, which is, she came over lock, stock and barrel for everything because, as I said, Mum had absolutely had it with the Newcastle team. and it just became really quite a problematic. And I knew of all of this. I'd moved over to Sunderland into the end of 2018, so I knew what was coming when she was transferring to us. And I knew this was going to be really difficult. And because I'm the only MS nurse here, there was nobody to sort of go, to pass it on to somebody else. So it became sort of, I had to face this head on, and I had to kind of roll my sleeves up with it. So before she came over to us, she successfully switched over to Ocrevus. That helped us out with the venous access. However, it did mean that the portacath was causing problems because she needed that flushing every 4 weeks. That became a huge issue for her, to the point where that was removed. So the kind of handover to the new MS team, the new mental health team that she'd become part of as well. They tried to transition her into adult services, and that didn't quite work. It has now, but also the gastro team, and also she didn't attend to any of my appointments, which was really quite tricky. She managed to go to one of my consultant neurologists, who changed her mind about the nature of the care provided here at Sunderland. So she kind of had a really good experience with Dr. Petheram, in case you're wondering who I'm talking about. So she had a really good experience with her. So that sort of triggered a little bit more hope from our mum that, this could be good. So she finally attended my clinic, which was absolutely wonderful. Anyway, so we got to a point where Charlie was not accepting MRI scans. She was on Ocrevus, and we could not. We're a district general hospital. We couldn't do general anaesthetic MRI scans because she'd sort of burnt bridges with our previous hospital. We couldn't organise those MRI scans to take place as frequently as we needed them to happen. So essentially, we had a choice to make. She was either going to go onto a treatment that required very little in the way of monitoring. Oh, did I mention she wouldn't have bloods taken? She kind of, so it just became an absolute headache and nightmare for her, for a mum, but also for every service that was involved in her care. So for us, we had to make a sort of a decision. There was lots of conversations went on with her. What should we do? Where should we go with this? All the variables of what we should do. So we kind of, what should we do? And I think, is this a poll as well? Can we bring this to a poll? What would you do? Which DMT at this point, knowing that she would not have bloods done, we couldn't do MRI scans easily, and we were struggling with blood monitoring, and but she still had quite active MS. So those are the sort of options available, although we went back and forth over a period of about 4 months, I think it was, Kate, wasn't it, between sort of our last infusion and the next one. So we had this decision to make. So would we continue with subcut Sabri and carry on with the general MRI, the general anaesthetic MRI scans as and when we could get those monitored? She was still JC negative, but we were struggling with her getting the bloods done again, like I said. Would you go on to cladribine? Would you consider, continue with the Ocrevus with reassurance and regular portacath flushing? Would we keep that in? And would we consider ofatumumab or any of the brace products, which we knew would be a safe bet? Or any other options, as Jola mentioned before, not going on a treatment? Would that be a potential? Because it was a real potential at one point, because we were scratching our heads thinking, where do we go here? So, Kate, have you got anything to add to our lovely Charlie?
No, I think one thing you've alluded to, perhaps, and it's on the slide there, which I think is relevant to just mention, is that she was mentioning this end of dose effect with
Oh yes, I did. Yeah, which we disagree on, don't we? Yeah.
Well,
it's not that we disagree. Yeah, okay. But I have a number of patients, I don't know about you, Jola, who mention that they have an end of dose effect on the ocrelizumab. and it's called many things, crap gap, etc. We're calling it end of dose effect because it's a bit nicer. But it's sort of, there's quite a lot of people mention this, and every time me and Kate have a conversation about it, it's, well, it's not going to happen. It's not the mode of action of the drug, and but the patients are adamant that this is happening round about 6 weeks before 6 to 8 weeks before they're due their next infusion.
No,
So I think we
we've
probably
got
no, Jola, what's your kind of observation of this? Because we see it. I don't think there's a very good biological explanation.
No, I don't
Yeah.
think it's biology. I think it's a psychologically that people are expecting, and I think it's more common in patients that have come off natalizumab and go on to 6-monthly treatment. So I think some of it is the not seeing a healthcare professional effect, and that
Yeah.
psychological reassurance we give just by them seeing someone. So yeah, there is no biology apart from, unless you say,
Yeah.
come, I'll give them a call at 6 weeks before. Well, that's not, capacity.
And I think we make
Yeah.
this assumption, don't we, that having infrequent treatments is good. And I guess this is part of the debate, isn't it? That having infrequent treatments is better and
Yeah.
good, but there are patients that benefit from psychologically and socially and for lots of different reasons about having more contact with healthcare.
Definitely.
And
Definitely.
whether that's
Yeah.
from 4 weekly to 6 weekly treatments or to kind of a 6 monthly treatment. There is one question, which I think is a reasonable question in the chat. So how do we know the MS is still active? So how do we know that she needs a high efficacy treatment, given the potential risks if we can't monitor and scan her?
So we can actually monitor and scan. We have, our last scan was it 2 years ago? It was about 26 months ago, before she came over to us lock, stock and barrel on a general anaesthetic. The issue arose when we got her coming over to us, where we didn't have that easily accessible. And she has ongoing symptoms. She has ongoing problems with her MS. She has new symptoms. And the problem with this young lady is she does have a lot of psychological influence on some of those symptoms with her non-epileptic seizures. She knows that. She owns that now, and she's very, very aware of that. But I think sorry, Kate, what were you going to say?
I think I was going to say, so I guess from a disease inflammatory activity point of view, it's a good question in that we don't know for sure, but we know from evidence of other people that have been on natalizumab and stopped it, that when you stop it, there is a high risk of disease reactivity and rebound. And she's young, she's 25 with a pediatric onset MS, that, from a population point of view, we have every reason to believe that she would continue to be active if we stopped treatment. And I think that would be potentially, therefore, quite a risky thing to do. And, the risk of stopping treatment and not switching is that you have a devastating relapse that you don't recover from. So I think that would be my reticence as to, because the temptation, I guess, is to say, well, let's just stop everything and see what happens. But I think in this situation, that's very high risk. So should we go for the poll
Yeah.
result? What everyone else would do before you tell us
Have a little look.
remind me what I did, what we did.
Okay. Oh, right. Okay, that's quite interesting.
You sure you don't have a Bart's crew on here, Jola?
Wowzer. Right. Okay. So there you go. Over half decided cladribine would be the right thing to do.
So we can go. I'll tell you why.
I can't vote. So this isn't me skewing the
You're pressing the button lots of times. We probably need to move on, but I think that's interesting. My concern with cladribine is the lack of ability to monitor her radiologically, because
and lymphocyte count as well. We wouldn't be
want
able to
know
do,
whether she was having activity at 3, 4, 5 years, which you might struggle to do without ability to do scans easily. But I think that would be my concern. But it's certainly there as an option, isn't it? Should we move on to what?
Yes, what we actually did. So there was lots of MDTs, many discussions. And what we were really looking at was the risk of activity versus the parameters of which Charlie would accept care, an intervention. We had to consider the needle phobia, the claustrophobia, spelt correctly, and panic attacks and non-epileptic seizures. The things that came abundantly clear were the communication between all of her teams that were looking after her, and if that wasn't useful and effective, then we were going to get nowhere with this young lady. So all of these things that came up here were essentially building relationships. They were building up things that were necessary to get Charlie to invest in the actual care plans. So there was a lot of work done behind the scenes from my perspective, working with the other teams. Gastro, I attend appointments for trying to empower Charlie, which we actually have done now. We switched her onto ofatumumab as it goes, because this negated the need for the blood monitoring. It allowed us at least a little bit of breathing space to sort of build up that trust, so that we could physiotherapy, are working on her breathing techniques for getting into the scanner. So there's been a lot of psychological help to try and get us in there, and successfully. We've actually just had a new open scanner, which we're hoping to get our match fit for pretty soon. And basically the final decision was made by Charlie. She actually made the final decision, and that was outside of the appointment with our mum, which I think was a massive step forward. And soon, sort of around the same time, she moved out of the sort of the family home, moved in with our partner, and started to establish our own responsibility for our own healthcare and making our own decisions. And my conversations are very much just with her now. And she just engages more. She contacts me all the time. We get emails, we get all manner of contact. And because I know it's surprising that she went on ofatumumab when she's needle phobic, but the very fact that she couldn't see the needle surprised herself when we were going through the options, that it was something she was able to do, and it actually cut one of the apron strings, which was a huge step forward in her future healthcare. So I think we've successfully had her on this treatment now for almost 18 months. We're yet to get her in the scanner, but that is a work in progress. She's doing so well. So from that perspective, I'm just, I'm delighted with the outcome of the care. She's delighted with it. And that's all we can ask for. She's engaged with the treatment, she's taking it, and there's very little in the way of it.
I think this is a good example of a case where patients are going to change when they kind of grow with their condition as well. So the treatment that you choose in a pediatric
Well, you're giving it, aren't you?
population, there's perhaps less control from the patient and more control from family members. And so this is an example of how a patient, when they choose, might make different choices. So that's kind of really interesting. We don't have any questions in the chat. There's nothing in the Q&A. Although Gillian's asked me, do we monitor her B cells? So no is the answer to that. We had an interesting discussion in our regional MDT this afternoon about measuring B cells, and I don't think it's something that we necessarily do regionally for generally patients on oclizumab or ofatumumab, and I think that's still open for lots of debate and controversy within the community, but certainly I don't feel particularly uncomfortable with that at the moment, particularly on ofatumumab. So my case.
I was just going to highlight that case highlights another reason for switching, which is when people move teams.
Yes.
So when you're switching teams, often the new team will often relook at a case in much more in-depth look, rather than if you stay with the same clinician. I'm not saying that patients should move teams every 6 months, because that'd be a nightmare, but you do get a review that is probably different.
Yeah, because I'm thinking, so when I see someone move, that's a new patient to me, not so it's a whole another review. Then that's a really good, again, but not to refer lots of patients, please. So my case study is a little bit different. So, but I'm sure the story will be fairly familiar to lots of people. So she's 51 now. She's a veterinary nurse. She initially had her first symptom in May 2006, but is perhaps not uncommon. She wasn't diagnosed with MS until May 2015. Once she was diagnosed, she was started on treatment fairly quickly. So started on dimethyl fumarate in August, but didn't tolerate it at all well and was only on it between August and September 2015, and it was stopped because of flushing. One might argue that that could have been given a bit longer, but it was a patient decision to switch. And then she was switched to Plegridy, again, patient choice, and relapsed, perhaps not surprisingly, on that. And then was in November 2016 commenced on fingolimod, which clinically she's done very well on in terms of MRI and relapse activity. She's not had any relapses. MRIs have been stable, but in November 2021, so 18 months ago, she was diagnosed with paroxysmal AF. And in order to control this, so that was symptomatic with palpitations, and she became incredibly bradycardic on bisoprolol, presumably because of the interaction with fingolimod. So we've tried to persevere with this for a while, but we kind of did feel that there was an opportunity to maybe help her whilst, because obviously the choice of antiarrhythmics is quite limited for somebody on fingolimod, and lots of the other treatments for paroxysmal AF are contraindicated, but she wasn't tolerating the combination of the beta blocker and the fingolimod. So we can open the poll up for this one. And whilst we look at the poll, while you look at the poll, I've just maybe opened the panel up. So is there anything else that you would like to know about her in terms of kind of her and her lifestyle? I've told you very little about her in a very medical way compared to the lots of information we've had before. I do have more information just in case you were worried.
You do know more about patients.
I do know more about her than she's just 51, yeah.
You do.
So the things I know about her is that she's really very fit. She ran the Great North Run in 45, I think I've said 45 minutes. That seems incredibly quick, but it might be an hour and 45 minutes, but very quickly. She's a very busy life. She's got teenage children and she works full time. So, you know, she needs something that's going to fit into that lifestyle.
She's absolutely no time for appointments. She's one of those people who just, you know, no, thank you.
Something and kind of forget about her MS, which up to this point she pretty much has been doing. What would you do in Bart's, Jola, apart from cladribine?
I'd like to say not all of our patients are on cladribine.
I haven't even put it there as an option, to be fair.
Oh, I know, because you're not a Bart's person.
Yeah.
Yeah. We'd measure neurofilaments and then we'd put her on cladribine. No, I jest. They are the two buzzwords for Bart's. But it would put on the patient. From what you've implied, you'd be like, she doesn't want to be reminded she's got MS, but we're then happy taking fingolimod. So therefore, you know, would take something daily. So I am looking at an anti-CD20. I'd want her to be on a high efficacious treatment. We're a high treating center. And then it would be down to each of those drugs, ocrelizumab, ofatumumab, looking at patient choice. We haven't started or switched anyone to glatiramer or beta interferon in a very long time, unless they've come to us on it and they want to remain on their existing treatment. So yeah.
And just before we get the results of the poll, I don't want to change anyone's mind, but bearing in mind what we've talked about before in terms of practicalities of switching, particularly from fingolimod to other high efficacy treatments, do you have any concerns about the practicalities of that switch? And might it kind of lead you to choose one anti-CD20 over another? Not that, I have favorite.
It's a lymphocyte count. We worried. So I don't think you mentioned what her lymphocyte count is, or I've got a really bad memory. Yeah. So yeah, we'd worry about the lymphocyte count and the issue about rebound. So it might be that you want to look at that closely to sort of monitor for that as well.
So that was kind of my concern, is the balance, again, like we're saying, the balance of avoiding rebound, but not adding another treatment too quickly in terms of cumulative immunosuppression and side effects. And I guess my other slight concern was those cases I don't think we've seen it. I'm not sure it's been reported, but the concern if you switch with fingolimod and your lymphocytes haven't repopulated or haven't been released into the bloodstream, if we then give, for example, ocrelizumab, and there are still lymphocytes waiting to come out, that you might have a kind of similar picture.
Yeah, it is. It is going to first principles and trying to work out where can cells be hiding, what's going on, and actually look at the risk factors. But it's each patient individually. We know some patients take months, years for their lymphocytes to come back up to normal, and some they don't really decrease that much to start with. So.
And we haven't kind of covered it here, but we have it's not in this case, but it might come up in questioning, but we have a similar problem, don't we, with patients that are switching from dimethyl fumarate, particularly that have become lymphopenic on DMF.
Yeah.
I had a case that I discussed in our MDT today that, remains lymphopenic below 1 9 months after stopping at DMF, and how long do you kind of hold your nerve for before starting another treatment that may also deplete their lymphocyte count, and then you don't want to throw out the baby with the bathwater, do you? So hopefully people have had enough time to listen to us and have a think about what they would do. So if we'll have the poll results. So most people would agree for a switch, and most people would agree that a high efficacy treatment switch is appropriate and sensible, with a slight preference to ofatumumab, which is quite good because that's what I did. So it's always gratifying to be backed up by peers and colleagues. So the patient's preference was for another high efficacy treatment. Like you say, Jo, she didn't want to drop down to an injectable brace therapy. And I discussed it in our regional MDT. It was felt that she was, historically eligible for the anti-CD20s. And my preference was based on just a kind of hunch and the mechanism of action of the medications. My preference was slightly for ofatumumab, but given that you'd be dosing her, there's the induction phase where they have frequent dosing for the first month and then every month. So you're going to catch any of those lymphocytes that are being released. So that was my reasoning behind that. There is the question: if a patient's lymphocytes are low or haven't repopulated, do they need the next dose of their disease-modifying therapy? I think that's quite dependent on what treatment they're on. So I think for terms of cladribine, you wouldn't give the second dose of treatment if they haven't repopulated their lymphocytes. That's right, isn't it?
That's after both weeks of year 1, not between
Yes.
week 1 and week 5.
So you would check the bloods just before their second year of treatment. Yeah. They haven't repopulated above 0.8, you wouldn't give that second year's treatment. For most other drugs, that you wouldn't dose depending on lymphocyte count. So whilst most centres, I think I'm fair to say, do not treat based on lymphocyte counts, some centres I think are using individualised dosing for ocrelizumab and measuring B cell subsets and only retreating when they repopulate. But that's kind of off license and not part of the kind of recommended treatment. So we don't do that locally. We treat people, on a 6-monthly for ocrelizumab, on a monthly for ofatumumab, regardless of blood treatment.
Yeah, we're the same. We treat as per license in the main.
But I think it's an emerging area that probably will change with time. Interesting, I think I'm aware that one of the centres that is doing it nationally is probably going back to 6-monthly dosing for ocrelizumab. We don't have the evidence, particularly for individualised interval dosing, although I suspect if we get enough data, we will look at that. And I think as well, it came up today in the MDT that lots of people aren't measuring lymphocyte counts on the anti-CD20s at all. There's no kind of obligation in the SPC to do so. So any other questions? Of one other question? Oh no, I've answered it. There's no evidence for an association with lymphocyte count reconstitution and disease activity. I think that's an unanswered question, but I wouldn't be confident to kind of state one way or the other. Jola, Carmel, do you have any?
No, I've not seen any evidence, and I think it's an evidence light zone, even if it does exist. But even infection risk, it's not always a definite. So yeah.
No,
Okay,
I think
it does look more of a statement than a question, though.
Yeah. We kind of, I think, again, it's interesting because we don't have the data, for example, with things like DMF, but we're not seeing lots of people, you know, having lots of disease activity despite being off treatment when their lymphocytes remain low. And I've heard other people say that as well, that it does seem to correlate, but I don't think we have the clear evidence to know that for sure.
Okay.
I am nearing the end. So did either of you have any quick questions or queries on my case? The room?
No, I think we're getting pushed for time now as well, Kate.
Oh, are we? Sorry.
Yeah.
Right. So, in conclusion, we do have increasing evidence for high efficacy treatment from registries. But as I've said, I don't think these registries, you know, I think the more data you get in, the more about individual patients is diluted. And so it's incumbent on us to really take that data, but apply it to our individual patients, but with the caveats that it doesn't tell us everything about them. And they don't tell us much about safety either. I think that's really important. And it doesn't tell us anything about the patient preference. And so it's all about shared decision making using all the available information, whether that's evidence from registries, clinical trials. You know, I don't think we should underestimate the unofficial anecdotal evidence we gather from colleagues as well, and bring that all together to make the best decision for our patients. So we've got 6 minutes, I think. Am I right? So we do have a question in it was a statement on their own paper. Excellent. Okay, so that was okay. I think that's worth pointing out to the group, to the audience, though, that it was a statement based on a paper in 2014 as part of the Cambridge group looking at patients post Natalizumab. So that's specifically looking at disease activity related to lymphocyte repopulation in Natalizumab, and I don't think that could be extrapolated to other disease-modifying therapies which work in different ways. But thank you for pointing that out. So thank you very much, everybody. What is the name of the paper? Perhaps we'll try and answer that offline and circulate that for you. But I think if you Google the name, then we'll be able to find that.